Hello and welcome to the MedSurge. In this video, I'm going to be talking about burns. This is the first video of the series of burns, and in this video, we will cover the definition, pathophysiology, clinical features, and how to assess the burn severity. Now let's get started. Before getting started, we have to know what a burn is. A burn is an injury to the skin or other organic tissues, primarily caused by heat, radiation, radioactivity, electricity, extreme temperatures, or contact with chemicals. It can cause multi-system trauma, and that will result in respiratory issues, circulatory compromise, and wound healing problems. So as you can see, burns are underappreciated injuries that are associated with substantial morbidity and mortality. Burns can cause damage in a number of different ways, but by far the most commonly affected organ is the skin. But damage to airway or lungs have life-threatening consequences. Now let's talk about the pathophysiology behind it. The cause of circulatory changes following a burn is very complex. The changes occur because the burn skin activates a web of inflammatory cascade, and it leads to a vastly increased vascular permeability and vasodilation. So water, solutes, proteins will move from the intravascular space to the extravascular space, resulting in the development of edema. And if there's edema, that's going to eventually impair the tissue perfusion. This flow occurs over the first 36 hours after the injury. So that means if it's a small burn, this reaction will be small and localized. As the burn size approaches 15% of total body surface area, this loss of intravascular fluid will go to a level where it's powerful enough to cause a level of circulatory shock. When we're talking about the clinical presentation, burns can cause a multi-system involvement. That means your skin, respiratory system, cardiovascular system, central nervous system, any of these systems can get involved. But first, let's talk about the local response. The local response of a burn injury can be illustrated by the Jackson model. In here, there are three zones: zone of coagulative necrosis, zone of stasis, and zone of hyperemia. The zone of coagulative necrosis is the area that is closest to the heat source. So when there's a lot of heat, the cellular proteins will undergo immediate coagulation and the cells are dead in this area. The zone of stasis, there's damage to the microcirculation because of the inflammatory mediators, and because of that they have hypoperfusion in this area. But this area is potentially salvageable with adequate resuscitation or surgery. The zone of hyperemia is the most distant area, and there's a production of inflammatory mediators which results in the widespread vasodilation and capillary leakage. Now I'll go through system by system to see how a burn would affect this system. First one, the very important system is the respiratory system. The heat can physically burn the nose, tongue, larynx, and once they are burned, these linings can swell. And if they swell, what happens is that they can block the airway. If there's thermal damage to the lower airway, that will result in the rapid swelling of the respiratory epithelium and detach it from the bronchial tree. This can create scars, and those scars can also go and block the main upper airway. If this patient is having a full thickness burn across the chest, this can physically stop the ribs from moving because burnt skin is very thick and stiff. Because of the widespread inflammatory response, these patients can also have acute respiratory distress syndrome afterwards. In the cardiovascular system, because of the vasodilation and increased capillary permeability, there's a reduction in the venous return. And across the burn tissues, there's a great fluid loss. And along with the vascular permeability, this can result in hypovolemia. And if there's hypovolemia, there's going to be a decrease in the preload. So both of these mechanisms together will reduce the cardiac output. So when the cardiac output is reduced, basically the organs that needs to be perfused will not get perfused properly. So your kidneys, gut, they will have ischemia. Central nervous system effects are most commonly due to carbon monoxide poisoning. A majority of oxygen in the blood is bound to hemoglobin within the red blood cells. So oxygen is transported to the tissues in this way. But this complex is reversible and they can dissociate when there's a cell who needs oxygen. Carbon monoxide has a high affinity for hemoglobin and it displaces oxygen from the hemoglobin molecule. But when they form the complex, it doesn't dissociate very easily because it has a half-life of 4 hours. So they can present in a range from mild headache, nausea, and decreased visual activity to more severe forms like hallucinations, confusion, and coma. They can also have a cherry red skin, which is quite rare. Immune system. When there is a burn, you basically lose the skin integrity, which is protecting you from the environmental hazards and infections. There's also a significant reduction in the cell-mediated immunity in a large burn. So these patients are more susceptible for bacterial and fungal infections. Gastrointestinal tract. The microvascular damage and ischemia to the gut mucosa will increase the translocation of gut bacteria, which can become an important source of infection in a large burn. When we're talking about the skin, it can get damaged in different ways. If there's a circumferential full thickness burn to a limb, when it swells, it can act as a tourniquet. And if this is untreated, this can impede the perfusion and later will progress into a limb-threatening ischemia. Following a burn, these patients will have a hypermetabolic state, so they can have increased muscle breakdown. So in a summary, these patients will have dehydration, hypovolemia and circulatory failure, respiratory problems, carbon monoxide poisoning, reduction of cardiac output, increased susceptibility for infections, gut ischemia, damage to the skin and limb-threatening conditions, and hypermetabolic state. Now that we've covered the pathophysiology and the clinical features, now let's go and talk about how to assess the severity of the burn. First, let's talk about the depth of a burn. This is your skin. There's 3 layers: epidermis, dermis, and the hypodermis. Burns can cause damage to the epidermis, dermis, hypodermis, or the underlying bones and the muscles. And depending on the depth of the damage, we divide the burn injuries into 4 grades. The epidermis is the thinnest layer and it basically acts as a protective skin barrier against infections and environmental hazards. Burns that affect the uppermost layer of the skin, that is the epidermis, are classed as superficial first-degree burns. So if there's a damage to this layer, we will be prone to infections. The skin will become red and it's quite painful. Blistering will be present and there's minimal tissue damage. Below that is the thick dermis, which contains the blood vessels, free nerve endings, glands, and skin cells. Second-degree burns involve the entire epidermis, papillary and reticular layers of the dermis. So they can have vesicles, blisters, and it's extremely painful because of the viable free nerve endings being exposed. In the hypodermis is where you get the subcutaneous tissues, arteries, veins, and nerves. Because of the presence of fat, it's going to act as an insulating layer and regulate the body temperature. In a full thickness burn, that is a 3rd-degree burn, it can extend up to hypodermis. So because of that, it will not be painful due to the damage of free nerve endings. They've basically lost all 3 layers, so these patients will be hypothermic and susceptible for infections. These burns cannot epithelialize. Finally, a 4th-degree burn involves injury to deeper tissues such as muscle or bone, which is often blackened and frequently lead to loss of that burnt part. Now you guys know how to grade a burn injury according to the depth of invasion. Now let's go and assess the extent of injury. To assess the extent of injury, there are few methods. The first method is rule of nines. It's a useful and a practical guide to determine the extent of a burn. In Wallace's rule of nines, the extent of burn is given as a percentage of the total body surface area. The body is divided into 11 areas that are in multiples of 9, but that excludes the perineum, which is 1%. It states that each upper limb is 9% of total body surface area, each lower limb is 18%, the torso 18% on each side, and the head and neck is 9%, and finally the perineum 1%. The second method is the Lund and Browder chart. This chart is most commonly used to assess the burnt body surface area in children and infants. They use different percentages in pediatrics because the surface area of the head and neck relative to the surface area of the limbs is typically larger in children than adults. The third method is the rule of palm. In here, an area of a palm is roughly equivalent to 1% of total body surface area, and it's used in outpatient settings in cases of small burns. However, it's not accurate for burns more than 15% of total body surface area. In the next video, we will cover about the management aspect of burn injuries. So stay tuned. Thank you for watching until the very end of the video, and if I've helped you in any sort of way, and if you guys like this video, please hit the like button and comment down below. And on your way out, please hit the subscribe button. I hope to see you guys in the next video, and this is the MedSurge.